On today's show, we're discussing the first clinical practice guidelines for cardiovascular kidney metabolic syndrome, known as CKM syndrome. This is the JAMA Medical News Podcast. I'm Associate Managing Editor Kate Schweitzer. News Director Jennifer Abbasi is here to talk about her story. Jen, thanks for joining.
Happy to be here, Kate.
So, 3 years after the American Heart Association first defined CKM syndrome, an interdisciplinary group of medical organizations has released inaugural clinical guidelines that consolidate recommendations for the health disorder and its constituent parts, including obesity, which is considered the root cause of CKM syndrome. Before we get into some of the takeaways from the guidelines, remind us what this syndrome is.
Yeah, so the guidelines define CKM syndrome as an interrelated condition that's characterized by the interconnections between metabolic risk factors, chronic kidney disease, and cardiovascular disease. I spoke with Dr. Chiadi Ndumale, chair of the Guideline Writing Committee and director of obesity and cardiometabolic research at Johns Hopkins. He explained that as the prevalence of obesity has increased, surplus body fat, particularly that metabolically active visceral fat around the waistline, has driven up the number of patients with overlapping diabetes, chronic kidney disease, and cardiovascular risk factors. And that's combining to cause excess cardiovascular events and early death. Over the past 15 or so years, this trend has led to a plateau in a decades-long decline in cardiovascular mortality. Dr. Ndumale said that these multi-system consequences of obesity are now catching up to us.
And at the same time, with newer therapies, opportunities for preventing and managing these clusters of health issues have improved.
That's right, but this is best achieved with holistic interdisciplinary care, which can be challenging to deliver in a fragmented healthcare system. So as caring for patients is becoming more complex, the new guidelines aim to help health professionals who see patients across the spectrum of CKM syndrome, including primary care clinicians, diagnose, stage, treat, and monitor the condition. The AHA and the American College of Cardiology developed the guidelines with the American Society of Nephrology and the American Diabetes Association and its Obesity Alliance.
And Jen, what are some of the most important things to know about the guidelines?
Well, as I mentioned, they provide guidance for staging the condition, with stages from 0 to 4. In order to stage and then treat, you have to identify CKM risk factors. The guidelines emphasize that all patients should receive regular assessments of metabolic risk factors. One of those metabolic risk factors is obesity. An important takeaway for clinicians is that the guidelines advise regular assessments not only using body mass index, but also waist circumference. And that's because that excess weight around the waist is so important for the downstream effects.
Another major emphasis in the guidelines is that kidney disease needs better recognition as a cardiovascular risk factor.
That's right. A lot of kidney disease goes unrecognized until later stages because it's not symptomatic until pretty far down the line. And until recently, there wasn't a lot that could be done about it as it developed. But now that there are effective treatments that can be used earlier, the guidelines recommend regular testing of all adults using estimated glomerular filtration rate. And for those with stage 2 CKM or higher, urine albumin to creatinine ratio.
Now, the guidelines discuss other risk factors that should be identified, like pre-heart failure, and they provide treatment recommendations based on staging and various combinations of conditions that patients may have. They also discuss the importance of team-based care for CKM syndrome, especially for patients with a confluence of conditions.
Yes, interdisciplinary care is sort of foundational to these guidelines. But the guideline authors recognize that this isn't easy, and so they really encourage the idea of having a dedicated point person who coordinates CKM care. Dr. Ndumale said he thinks existing positions like diabetes educators, heart failure case coordinators, and nurses can be adapted to this.
Thanks, Jen. All right, if you'd like to learn more, we'll include a link to Jen's story in the show description. This week, we also published a piece on how new breast cancer screening guidelines are fueling a debate on who should write screening guidelines, generalists or specialists. You can find that and all of our stories at jamamedicalnews.com. Thanks to Jen Abbasi for joining me. I'm Kate Schweitzer. This episode was produced by Daniel Morrow at the JAMA Network. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com. Thanks for listening and join us again next week.
This content is protected by copyright by the American Medical Association with all rights reserved, including those for text and data mining, AI training, and similar technologies.